Hi everyone, my name is Adrienne Nicodemus and I am doing my presentation on sexual and gender identity disorders. And I'm hoping that everyone had the opportunity to look at my PowerPoint slides because went through the criteria of each diagnosis according to the DSM. And I have tons of information to cover, so I wasn't going to repeat anything. I was just going to kind of jump right in, and that kind of give you guys some background information to go off of. I'm going to start my video talking about sexual dysfunctions, and then we'll go into gender identity disorder and then talk about changes in the DSM-5 with sexual dysfunctions and gender identity disorders. So just to give you guys a little bit of a recap, sexual disorders and dysfunctions have to do with the impairment in normal sexual functioning. This refers to the inability to perform or reach an orgasm, painful sexual intercourse, strong repulsion of sexual activity, or an exaggerated sexual response cycle or sexual interest. A medical cause must be ruled out prior to making any diagnoses. Paraphilias have to do with repetitive sexual fantasies, urges, and behaviors. These fantasies, urges, or behaviors must occur for a significant period of time and must interfere with either satisfactory sexual relations or everyday functioning. This diagnosis also they have a strong sense of distress in individuals that are diagnosed with paraphilia. They typically recognize the symptoms as negatively impacting their life, but they feel as if they have no control over it. So, causes for sexual dysfunctions. There's physical causes and there's psychological causes. Physical causes are typically medical conditions that can cause problems with sexual functions that include diabetes, heart disease, neurological diseases, hormonal imbalances, menopause, chronic diseases such as kidney or liver disease, alcoholism or drug abuse. And there's also different side effects from certain medications such as antidepressants can also affect sexual desires and functions. And then there's psychological causes, which are work-related stress and anxiety, concern about sexual performance, marital or relationship problems, depression, feelings of guilt, or effects of past sexual drama. Talking about the prevalence of sexual disorders, in women, 23 to 43% of women report a lack of sexual interest. Around 14% experience arousal disorders, and the prevalence of pain disorders, which include dyspareunia and vaginismus, is estimated to be anywhere around 1% to 21%. And in men, 10 to 20% experience erectile disorder. This number jumps to over 50% when we're talking about males over the age of 70. And 8% experience male orgasmic disorder. So overall, about 31% of men and 43% of women state that they have some type of sexual dysfunction. When looking at the associated disorders and comorbidity of this, 41% of men and 47% of women with low sexual desire experience other sexual dysfunction disorders. Poor relationship adjustment is the most consistently associated with hypoactivity sexual desire disorder. And also, like I stated previously, general medical conditions are also associated with these. Social phobia has also been associated with premature ejaculation. Now we're going to go on to treatments for sexual disorders and the duration of treatments. And typically, treatments can last anywhere for 10 to 20 weeks. Typically, they're anywhere from 10 to 12 weeks going to treatment once a week. There are a variety of psychotherapy treatments for sexual disorders, and these include cognitive behavioral therapy techniques, psychoeducation, systematic couples therapy, and bibliotherapy. And I'll start off talking about psychoeducation, and this includes just basic sex education, anatomy and physiology of sex, addressing the unrealistic expectations of the self and the sexual encounter, addressing various myths of sexuality. And then you can also apply CBT techniques in this that have to do with stimulus control, cognitive restructuring. Moving on to bibliotherapy. It's often applied within treatment formats with minimal or absent therapist contact, and an example of this would be self-help manuals, brief skills training, or education. It is cost-effective and considered a successful adjunct to psychotherapy for sexual disorders, particularly orgasmic disorders. Then pharmacological and medical interventions. Medicine is capable of treating sexual dysfunctions. They're normally utilized in place of psychotherapy, but the client needs to recognize that there is limitations with these. Pharmacological treatments focus primarily on restoring psychological sexual responses while leaving other important psychological and psychosocial concerns behind. These include poor couple communication, negative attitudes, and inaccurate beliefs about sex. So it's recommended that these interventions be utilized as adjuncts to psychotherapy. Following is a list of treatments that have shown to be effective for men in desire and arousal disorders, and these include vasodilators, which is Viagra, Levitra, vacuum and constriction devices, which is recommended for individuals with diabetes or spinal cord injuries, topical vasodilators, and in women, treatments include hormone treatment, Buspar, Provesta, and herbal treatments such as ginkgo and ginseng. We're going to move on now and talk about gender identity disorder. And this disorder includes strong feelings of being the wrong gender, feelings that your outward body is conflicting with your internal sense of either being a male or female. There's a lot of discrepancy when trying to figure out the prevalence of this disorder, especially in the United States. I found one study that was done in Ontario, Canada, and it was estimated that 1 in 1,000 children have the disorder, but it stated that many grow out of it, and only about 1 in 30,000 adult males and 1 in every 100,000 adult females they say are diagnosed with gender identity disorder and are actively seeking reassignment surgery. Symptoms can vary by age, and it's also affected by the person's social environment. But in children, they include being disgusted by their own genitals, being rejected by their peers, feeling alone, isolated, believing that they will grow up to become the opposite sex, having depression or anxiety, saying that they want to be the opposite sex. And in adults, they'll dress like the opposite sex. They often feel alone. They also have depression or anxiety symptoms. They want to live as a person of the opposite sex. They wish to be rid of their own genitals. And either in adults or children, there's cross-dressing, showing habits typical of the opposite sex, withdrawal from social interaction. Treatment for GID involves individual and family therapy. This is recommended for children especially because we want to create a supportive environment at home and in school for the child. Couples therapy is recommended for adults. Sex reassignments through surgery and hormonal therapy is an option, but research has shown that identity problems may continue even after treatment. For the prognosis of this, it really depends on how early the disorder is diagnosed, because it can reduce the chances of depression, emotional distress, and suicide. So, moving on to the changes to the DSM-5, we're going to talk about there's gender-specific sexual dysfunctions that have been added. For female, sexual desire and sexual arousal disorders have been combined. All of the sexual dysfunction disorders now require a minimum duration of 6 months, and this is just to try to eliminate overdiagnosing. Genitopelvic pain and penetration disorder is a new diagnosis to the DSM-5, and it merges the categories of vaginismus and dyspareunia. The diagnosis of sexual aversion disorder has been removed just because it's so rare and there's lack of supporting research on this. Subtypes to the DSM-4 included subtypes for all of the disorders, but the DSM-5 only includes lifelong versus acquired and generalized versus situational types. When talking about gender dysphoria, it's a new diagnostic class in DSM-5, and it changes the conceptualization of the disorder's defining features by emphasizing gender incongruence rather than cross-gender identification, that is under gender identity disorder. And DSM-5 recognizes the wide variety of gender and incongruent conditions. There's separate criteria sets for adults, adolescents, and children. And gender is also now used instead of sex. And then subtypes on the basis of sexual orientation have been removed because the distinction is not considered useful to professionals. A post-transition specifier has been added because many individuals after transition no longer would meet criteria for gender dysphoria, even if they do continue to undergo treatments to assist with the life of their desired gender. And that is all I have for my video, and hopefully that answers some of your guys' questions, but I look forward to seeing your guys' comments in next week's post. Thank you.